Thank you, Father.
Good morning, everyone. Thank you, Father. And Father Kaz has been our spiritual guide, for which we've been very, very blessed. By way of introduction, Marie and I met maybe just a little over 2 years ago. And when we met, I was very inspired by Marie as she was unfolding her work as a case manager for catastrophic trauma patients and providing them with spiritual care. So we then began to talk and we began to bond, and we came together with a shared passion and deep commitment to impact the spiritual care of patients. We were asking each other the question, how are nurses prepared to provide spiritual assessment, provide a spiritual plan of care, and advocate then for that spiritual care. And then I, as a dean of nursing, was questioning myself on how we incorporated this very, very important element of care into our curriculum for nurses. So we don't believe that our meeting was by chance at all. Rather, the more we work together, we know we've been joined together to really make a difference in the care of patients. So you see, we know, as we are nurses, and we know nurses, that's a large part of our world that surround us with my faculty and Marie, all her colleagues, and we know that nurses recognize their role in caring for their patients, and that they recognize that as nurses we care for the patient in their entirety. But we also know they lack knowledge, they lack experience, they lack practice, and they also lack an environment that supports this element of practice. So today we hope to bring you a little reflection of our work. Today we're going to begin with Marie, who will spend a few minutes discussing evidence-based practice for spiritual assessment. And then we're going to move into the major part of our presentation, which is the challenges and opportunities of spiritual assessment, and take you on our journey. And it's truly our mission.
It's my tremendous privilege to be here today for you with Dean Scoble, and I'm presenting a shortened version of evidence-based practice as it relates to the spiritual care of the patient. So I wanted to give this brief overview because many people think that the spiritual assessment, the spiritual care of the patient is sort of out there, right? We don't have time to do it. There's not a standardized program. The objective when I came to Elms College as a master's degree student was really take the past 15 years that I've been working with Father Seraphin and Father Kaz and in the ministry of the healthcare professionals for Divine Mercy to really write a curriculum for healthcare that would be directed towards nurses as a professional training program that's standardized, that would be very, very important for the nurse to really empower that. There have been many physicians, as you heard Gowrie yesterday, plus Dr. Christina Puchowski, who we will reference later, who's very famous, that has done a lot of work for physicians. So we really wanted to look at the practice guidelines, and I wanted to briefly show you that there really is evidence-based practice. So we all know what the PICO question is. The populations, the nurses in the acute care hospitals, the intervention that we would provide a formal training program to implement the spiritual assessment. We look at the comparison, nobody's doing it. The outcome would be the utilization of the spiritual assessment for every patient. So the question for evidence-based practice: would formal training of acute care nurses on the implementation of the spiritual assessment using Joint Commission guidelines result in a higher rate of utilization in the spiritual assessment with all patients by those nurses trained in the use as opposed to the nurses not trained? And I just want to mention in this picture, this is actually Father Kaz administering the anointing of the sick to a patient that we met when Father Kaz, Father Seraphin, and I were speaking in Bogota, Colombia at the World Congress on Mercy. And one of the participants told me that the wife of a very young mother was dying of aplastic anemia, and how the Lord brought us there and really had an intervention with spiritual care, because spiritual care at that time wasn't readily available. So Father Kaz was able to administer the anointing of the sick. We prayed the chaplet at the bedside, and I had a conversation with the head doctor there because he was really, really basically crashing before our eyes. They transferred him to the ICU, and he died 4 days later after we left Colombia. But his wife, we're still in contact. We still speak about this, and she now has become a witness to intervention for the spiritual care of her husband because it made such a huge impact. So what's the elements of evidence that's relevant to the topic, right? We always say, well, what's relevant? How are we going to do this? There's so much evidence. And I focused really on 37 articles out of about 200 that I'm working with on this project. And I'd like to bring to your attention a couple of key pieces. The Joint Commission requires the spiritual assessment, and yet they don't direct us how to do it. And they want a spiritual assessment done, and they only give guidelines because they're really not going to tell us how to assess a patient, right? On some of the research papers, for example, with Q, among the guidelines of spiritual care, none is available for critically ill patients. This article is 2016. Other references, the perception of the healthcare professional's ability to complete a spiritual assessment without training shows the assessment will not be completed. Why? Because we don't know how to talk to patients. And we're not trained in this area, right? We're nurses, just like the doctors are doctors. And then you see how beautiful the presentation of Gauri yesterday, how she showed us how she incorporated spiritual care. So I went for the evidence levels, level 1, level 2, level 3, level 4, etc., down to level 7 evidence. And I actually have articles in each section of evidence that is very, very interesting. It's too long for this presentation, but I guarantee you there is critical evidence that the spiritual care of the patient has an incredible outcome to their well-being. So basically, we want to see at the consistencies and what are the inconsistencies. The consistencies are nurses agreed that the spiritual care for the dying or critically ill patients is a top priority. What's the inconsistency? They're reluctant to provide spiritual care themselves. They think it's out of their realm of practice. It's not in their purview. Oh, refer the case to pastoral care, right? We don't have time for this. Let's just skip through. And in many facilities, some of you know I'm a catastrophic injury manager. I travel to all the facilities in New England. So the first thing I always check on the chart, did the patient get a tetanus shot? And did the priest come to anoint this patient if he or she was a Catholic? And basically, I would speak to some of the other nurses, and they're like, oh yeah, Marie, we don't know. You know, we're trying to start an IV here, you know. And a tetanus shot, their radar came up, yes, this is a big trauma case, etc. So you can see for yourself the consistencies, the inconsistencies, and I think an important point here is that we have to bracket our personal beliefs for an unbiased approach to spiritual care, right? Because sometimes we'll go into a patient and they're hardcore evangelists, whatever, and we're like, you know, I really don't want to have anything to do with this. Or it's another type of religion that you don't believe in and you might have a bias. So I want to just bring that up to don't be inconsistent and have your spirituality bias the patient, but really open up. And what are they in need of? how can we help them? So the conclusion is, for these particular articles, that the articles illustrated the importance of spiritual care for the patients, and this was verbalized by both the patients and the nurses, and the great need to integrate the spiritual care of the patient and medicine. Although there are many instruments out there, the HOPE instrument that Professor Gowrie shared with us yesterday, Professor Christina Puchowski from the George Washington University Center for Spirituality has the FICA tool, which we'll talk about a little bit later. There are other tools out there, but there's nothing standardized. And I went to the Pontifical Council for Life conference in January in Rome to meet Dr. Puchowski and hear her presentation. And this was very, very fruitful because there was approximately 600 healthcare professionals from all around the world speaking about the spiritual assessment of the patient. And one of the largest groups was from MD Anderson Cancer Center in Houston, which was really an eye-opener. So we're right on the cutting edge of trying to pioneer a specific program. So with training, healthcare professionals would benefit from an education program teaching them how to start a conversation about spirituality and perform a spiritual assessment. We focus on using the Joint Commission guidelines for the simple fact that facilities, particularly in the United States, they cannot receive federal funding unless they go for the Joint Commission guidelines, and the spiritual assessment is required. So that means a healthcare professional, if they want to pray with the patient during the process of the spiritual assessment, or engage in spiritual activities, they cannot be fired. And I think everybody needs to know that. Yes? And it opens that door. And then Sister Dr. Angela informed me that in Portugal, at her hospital, they invited the Joint Commission to certify their care. So this was a huge impact that our work actually could be protected by the Joint Commission worldwide. So, okay, so here are my million references. And now I will turn things over to Dr. Scoble.
Well, what we hope to accomplish today is to explore and gain some understanding around what the current state is in spiritual assessment. And I believe you may have a very good impression of what that is by now, but we have a little bit more of a context to give you. Overview of the professional implications of responsibilities of clinicians in relation to the spiritual assessment. Marie has already covered some of the Joint Commission requirements. We're going to drill down a little bit more so you can see what those are if you haven't been exposed to them before. Marie is going to reflect on the state of spiritual distress, and then we're highlighting a standard spiritual assessment. And then what we hope that you will enjoy, we're excited about drawing you in for an experience of provider and patient in spiritual assessment. So we've already provided you with a tool on your table, and we will walk you through that. And then conclude with what the challenges and opportunities are for implementing and promoting spiritual assessment in the care of patients, which is actually framing the project that Marie and I are on. This is beginning with a definition, and I believe yesterday, if you recall, Dr. Gowrie so beautifully presented, asked the question, what's the difference between spirituality and religion? And she demonstrated through her work that there are people that feel they're completely different, they overlap, or they're the same. But this definition seems to serve a good purpose for us. It's from the Association of American Medical Colleges and retrieved from 1999. And what this definition encompasses is the important points are it really recognizes spirituality as a factor that contributes to the health in many persons, and then that religion is a means of an individual's participation in religion is a means of their expression of their spirituality and their values. So I think it is a definition that can certainly apply. I would like to begin with a little reflection on the current state of affairs of spiritual assessment. And this is by no means a comprehensive literature review. The literature on spiritual assessment is really quite dense. Hundreds of articles, and very interesting too if you'd like to peruse it. But what we did find is that there was a great deal of emphasis on, and certainly answered the question, that there is no doubt that the religiousness or spirituality to patients by their health professionals was valued. And it's underscored by numerous articles, polls, attempts at incorporating it into undergraduate curricula, recommendations of professional organizations, and et cetera. So we begin with the requirement of the Joint Commission, which Marie touched on, the numerous studies that have shown spiritual health to correlate with both health and healing. This particular study, the first one on spiritual care, was a study conducted by these two authors, and at the time of their paper, they were unable to locate or identify any inpatient psychiatric program that had systematically integrated spiritual assessment and intervention into their program in order to promote clinical outcomes. And I thought that this is really particularly impactful after we talked about addiction this morning and the importance of spiritual care and religion. So what they have said here is they found that it's traditionally provided ad hoc, which means upon request, inconsistently to patients and families without integration and coordination of their emphasis. But additionally, what was found or can be found in several different articles, this one that I chose, is that this was based on a survey-based multi-site study that was conducted in Boston. And it was 4 Boston academic centers. And they were studying the desires of physicians and nurses to provide spiritual care. And what they concluded was that most physicians, 40% of their surveyed population, and most nurses, 74% of their surveyed population, desired to provide spiritual care within the setting of terminal illness, which was the population they targeted. However, when they combined the groups, there was only 40% that provided spiritual care, that there was only 40% that provided spiritual care, and they provided it less often than they desired. So that I too think is a very, very impressive study. We also know that community clergy and hospital chaplains hold a central role in providing spiritual care, and that role is more easily understood and accepted by health professionals. And what is less clear is the role of medical professionals, which was demonstrated in this particular study. And then, not to focus on any one of these, as it would take a great deal of time, but the importance of spirituality as an aspect of healthcare is reflected in a number of policy documents, and this is just a few. We know there's a wide range of tools and methods of spiritual assessment available. Dr. Gowrie presented yesterday a very interesting and beautiful approach with some suggestion and example questions. But again, to Marie's point, what we have found is that the value is has been very much demonstrated. The requirement, the value, and tools and methods, but yet we still see that it is not widely used. And then again, as Marie pointed out in her evidence-based nursing piece, that there is no standardized spiritual education curriculum in medicine or nursing. And in fact, Marie and I have perused a few nursing textbooks only to find that they were really insufficient, we felt, in their approach to spiritual care and assessment. So what are the implications for health professionals? What we found, or what we have found together, is that a number of patient surveys and polls demonstrate there's a discrepancy between what patients want and what they receive in relation to religious and spiritual needs. So another poll that I derive from is that 94% of patients who were surveyed in this particular study who have religious and spiritual beliefs designated that they wanted to talk with their health providers about it. 94%, and this was a pretty significant study. Moreover, these authors continued, nearly half of these patients who didn't necessarily hold specific religious beliefs still wanted to talk about it. And then, furthermore, while most patients wanted to discuss their religious and spiritual needs with their physicians, only 3% of them indicated that their physician did talk with them about it. And then there's been other studies, and another one I might cite is that 87% of patients in another study called spirituality very important in their lives, and that nurses and physicians agree that spiritual care would have a positive impact on patients. So there's all this sentiment and all this emotion around this, and yet we are still seeing that it is not occurring. So when we get to what are these implications, what I thought that I would share with you, which I found particularly interesting, and it particularly spoke to Marie and I, was that in 2016, a meeting of the American Medical Association's House of Delegates reviewed the whole topic of spiritual care. And they looked at recent research, they looked at the impact that spiritual care provides on patient satisfaction, and they made a statement where they recognized the importance of individual patient spirituality and its effect on healthcare. And with that, they came up with these declarations or statements identifying what healthcare professionals should know about. Spiritual care should be integral to any compassionate and patient and family-centered healthcare system model of care. And those of us in hospital systems or acute care systems know our focus is patient and family-centered care. They say spiritual care models should be based on honoring the dignity of all people and providing compassionate care. And Dr. Gowrie yesterday so beautifully presented about compassion. Spiritual distress or religious struggle should be treated with the same intent and urgency as treatment for pain or any other medical or social problem. That's a very impactful statement. And then the next one says that spirituality should be considered a patient vital sign. Just as pain is screened routinely, so should spiritual issues be part of our routine care. And then finally, that spiritual care models should be interdisciplinary and clinical settings should have a clinical pastoral education trained, board certified chaplain as part of the interprofessional team, which is extremely important. So the effect of spirituality on health. Dr. Podchowski, who Marie has noted, is very renowned as an author and her work in spirituality and the spiritual care of patients. She places spirituality on health into three major areas. And I touch on that because I think it's very relevant as we consider this important aspect of care. She says mortality is the first major area, and some observational studies suggest that people who have regular spiritual practices tend to live longer. There are also authors of large studies who've hypothesized that religious commitment may in fact improve stress control by offering better coping mechanisms, richer social support, and the strength of their personal and religious values. Coping as a major area, patients who are spiritual may utilize their beliefs in coping with illness, pain, and life stresses. And Dr. Podchowski goes on to explain that, for example, patients with advanced cancer who found comfort from their religious and their spiritual beliefs were more satisfied with their lives and more happier and suffered less pain. And then the final one, recovery. Spiritual commitment tends to enhance recovery from illness and surgery. And for example, a study Dr. Puchalski put forward, a study of heart transplant patients showed that those who participated in religious activities said that their religious beliefs were important, and they then complied better with follow-up treatment, what we saw was improved physical functioning, etc. So that's giving us a little context and backdrop, and I turn it over to my partner, Marie.
Thank you. My partner. So we asked the questions. Thank you so much. That was beautiful. What's the purpose of the Joint Commission requirement for the spiritual assessment? And really, it's not complicated. The purpose is for us to obtain critical information regarding the spiritual care of the patient, so a referral can be made to either the pastoral care department or the patient's own religious minister. That makes a lot of sense, right? So then we go into the Joint Commission requirements. This is right from their website. Does the Joint Commission specify what needs to be included in a spiritual assessment? And they say no. It's up to the individual organization to define the content and the scope and other assessments and the qualifications of the individuals performing the assessment. And I emphasize the word qualifications because nurses and other healthcare professionals say, we're not qualified. And the reason they say that is because they haven't received the adequate training. And that's the intervention that Dr. Scoble and I are hoping to change. So sample questions for the spiritual assessment is something that is very important. These also were proposed by the Joint Commission, and I want you to take a look at them because I'm not going to read off every one, but it's general information that they want us to gain. And from this, speaking to this point, I think one of the most important questions here, how does your faith help the patient cope with illness? That already tells us from the Joint Commission that they are expecting us to be a person of faith at the bedside. And for us, this can be very easy. Wearing a religious medal, wearing medals, somehow giving that tenderness of our heart to our patient. You know, how's God treating you today? What's going on? You know, you don't have to get all serious. And this is what I say, this is a serious subject, but sometimes the best introduction is very, very low-key, open-ended questions. And I want to tell you that it took Father Seraphin, Father Kaz, and I nearly 6 months to rewrite some of the questions. That is how important this is for this presentation today. So, the incorporation of the spiritual assessment, the basic overview is upon admission to the patient care unit, the nurse would complete the following normally. A nursing admission history, physical assessment, which includes the spiritual assessment. So like Professor Gowrie was saying yesterday, this really doesn't take extra time. It is part of patient care, and it is required by the Joint Commission. So we have that obligation. So we developed the nursing care plan. We have to verify if what is on the admission record is actually correct. I can tell you, having been in emergency rooms and critical care units most of my life, how many times the admissions folks put down unaffiliated instead of unknown, right? That makes me crazy because they may never know what it is. That information is entered incorrectly and prevents an automatic referral from pastoral care. And I want you to tell everybody you know, investigate what the patient's religion really is. Because God love the secretaries, they have the John or Jane Doe coming through the ER, what are they supposed to put down? I always say to the administrative staff, please put down unknown, because you don't know. It's not fair to the patient to say unaffiliated when you don't know. So I'm bringing that up because I can't tell you over 30-some years of nursing how many times I've seen that. So, as we progress through the nursing care plan, we use the information from the spiritual assessment for on the patient to facilitate the referral to pastoral care. So, if you take a look at your sheets, you'll see that these are the questions that we have written to gain the specific information that we're looking for. Is there a particular kind of spiritual or religious support that you would like us to offer you that gives you strength and hope? This is a very, very, very easy question, non-threatening, and I mention that because we don't really want to confront our patients. What's your religion? You know, like they do on the admission. And some people think that just because the admissions office, when a patient's conscience has asked, their religion is Catholic or Hindu or what, Jewish, whatever religion, that's it. That's a spiritual assessment, right? That's what we see happen. So we're asking them, what kind of support would you like? Are you a member of a particular religion, church, or denomination? Then, if they say, yes, I am. I am interested, and do you know the name of the pastor, the rabbi, the other religious leader? If not, would you like us to contact the pastoral care department so that we can send you the minister of choice? And I want to make it very, very clear that only a Catholic priest can administer to a Catholic patient the anointing of the sick. That is a sacrament. We as healthcare professionals, we can baptize anybody. But when you're calling for pastoral care, if you know somebody's in danger of death, you need to tell the pastoral care office, this patient is Catholic, we need the sacrament of the anointing of the sick, and please send a Catholic priest. And I think you've all heard my story working at the Brigham on a case as an outside nurse case manager. I had 2 patients from Guatemala, very Catholic country. Their religion was listed unknown. I talked to the family members that were there, and they were like, oh yeah, well, they haven't been to church in a long time. I said, that doesn't matter. You're telling me they're Catholic? This is an emergency. So I said to the secretary, please call pastoral care for a priest. Well, who comes up but the Lutheran female minister? And she sees me, I see her. We immediately started laughing because she knew I didn't want her. And of course, both of us are very gracious and loving. And she said, well, do you want me to leave? I said, no. Go in the room, pray the Our Father, pray. We need prayers. And so I called back pastoral care and said, we need to have a Catholic priest paged. So you see, the secretaries don't know all the time, even if you specify. But this is something that with in-service training, you need to make everybody on your unit aware. So then we're going further for the EMR record. So what's helping you get through this illness or injury? What else could we do for you spiritually? Would you like a copy of the Bible? That's for everybody, except those that are not Christian. Would you like a rosary if you're Catholic? Or I know when I was at Spalding as an inpatient, I always knew that EWTN had 9 a.m. Mass. And of course, the doctors wanted to have rounds at 9 a.m. Mass. And I said, no, you put me last because I'm having my morning Mass, because I do believe in going to Mass every day, most of the time. I say that because sometimes obviously you can't make it. So it has to be a priority. If a patient tells you I really want to have morning Mass, then talk to the medical team. Say, hey, listen, and starting on the first patient here, adjust the schedule. You can do that. You're in charge, right? So, would you like to have somebody pray with you? We can have somebody come from pastoral care. And this is if the nurse or the healthcare professional doesn't really feel like, I want to do this just yet. And I have a wonderful niece that graduated from nursing school in California, and of course she has the nurse's book that I've written. We've talked about pastoral care for years and the spirituality of the nurse. She came here for this conference, and I said to her, well, so how are you doing with it? She's like, Aunt Marie, I'm not ready. And you know what? I respect that. That nurse has to be ready. That healthcare professional has to be ready. But then she's telling me about the young pediatric children that she works with in the ICU, that, you know, Aunt Marie, I really did get the family involved, and we talked about prayer, and, you know, we made the appropriate referrals. So she's doing it in her way that she's comfortable with, and that's okay, because the job is still getting done. They still have the spiritual assessment in their EMR. So then we go on. How is this illness or injury affecting your family? What do you feel you need most in your current situation? So these are screening questions, right? So what if we go further? We're, let's say, in palliative care, and we're more involved with the patients. We're not in the emergency room or the ICU, where you see the patient for a very short period of time, and then you go. So the Joint Commission asked this question, as I mentioned. How does your faith help the patient cope with illness? So that means our faith can be visible. We are free to share that with the patient with their permission. So how could your convictions help that patient? So what are we to do? After you start talking to the patients, let's just say your beliefs are not compatible and they're black and white difference. So refer the patient to pastoral care and let the pastoral care department sort things out. But if your beliefs are compatible and you're comfortable in sharing your faith and the patient is open to the dialogue, then take this opportunity to bring hope and encouragement to the patient for coping with the illness or injury. So, a couple of points to remember. The nurse's assistants or other pastoral care, the nurse's assistants or other healthcare professionals does not replace pastoral care. Remember, pastoral care is the golden rule, the golden standard. The priests that are in pastoral care have specific training to be in pastoral care, as Father Kaz was talking about, the CPE program. If this pastoral care is not available, either through the hospital or with the patient's parish or the minister, then the nurse could assist the patient spiritually. And assisting in providing spiritual care can also take place only after securing the patient's permission to pray together and to discuss spiritual matters. So I wanted to bring up a couple of topics that are tough topics to talk about. So let's say the patient is aware of their situation. So you're in this conversation, it's getting pretty heavy duty, and you say, okay, you're aware of the grave nature of your injury or your medical situation. We know that the outcome may not be as what we would desire, and it seems to be weighing on you. Is there any way I can assist you? Would you like to share it with me? Another topic, family, permanent injury, employment concerns. With my catastrophic cases, most of the folks, they may survive, but they have permanent and total disabilities. They have loss of limbs, severe traumatic brain injuries that some of them come back, some of them don't. And their number one concern is their family and their employment, because obviously these people were working and they were injured at work, and most of them were the breadwinners. So a question that gets to the point but is very gentle: are you concerned about the consequences of this illness or injury? Not something like, well, I know you lost your leg, so now what are we going to do? Right? Not good. We need to be sensitive, because these patients are in shock during this initial phase. And some of these questions may not take place until the rehabilitation phase, right? When they're just learning that the disarticulated hip and the prosthesis they need to use are horrible and they don't work. So then we talk about, are you concerned about the permanence of injury, the loss of employment and financial difficulties, or family hardship? Many of these patients were barely making it. They're in labor jobs that were, $200, $300 a week, and the workers' comp does not cover everything. they're in dire straits. This is a significant worry and causes not only emotional distress, but spiritual distress because they're unable to pray during this crisis. The other is fear of dying. How many of us have resisted the opportunity to walk into a patient's room and start talking about them or talk with the family? We know the prognosis is not good. Don't use all technical terms. Well, are you concerned you may not survive? Is there anything I can do to help you? Are you afraid of dying? That's a tough question, but with your relationship with the patient, you know when that's the right time to discuss it. You will know in your heart. Do you believe in the afterlife? Do you know that life doesn't end in death but continues? Would you mind if I shared with you the source of my hope and joy? As a Christian, my hope is in Jesus for forgiveness of sins and eternal life. And so, depending on how you've taken care of yourself spiritually, something that Sister Angela and Dr. Gowrie spoke about is that self-care is critical. You need to know where you're spiritually at because you're going to be hard-pressed to take care of somebody else's spiritual needs and get into this level of question. The last one is the loss of a loved one. You hear about the multi-car accidents and the mother and the 3 children are dead and the father made it, or the father-in-law, and they're like, oh my God, what happened? You know, where's my wife? How can we tell them? What gentleness can we use? I know in one of the big accidents here in Providence where we had that huge fire at the nightclub, one of our patients, the fiance didn't make it, and the young man did. And he said he knew something was wrong when pastoral care, the attending doctor, two other social workers, and so like 6 people came in the room, and he knew right away, okay, this is not a good thing. But they at least provided the spiritual support for that patient. But these things happen. And so after the big meeting takes place and the patient knows it, how can I help you through this grieving process? What can I do to help you? Do you want me to just sit here? You know, just sitting in the room and being present to that patient, that's prayer. You are spiritually presence of Christ. You are there for them. No matter if you're starting on IV, no matter what you're doing, you are there as the representative of the Lord. So this is why this is so important, that we don't lose sight that we have a vocation. We may be nurses, we may be doctors, physical therapists, I can go on and on. We did not become healthcare professionals because the pay was so great and the hours are so perfect, right? Nights and weekends, no thank you. And I can tell you as a single mom, it was tough. It was tough. But my faith brought me through that crisis. And I thank God every day for my faith, because if it wasn't for Our Lady, I wouldn't be here. So, to go further.
Okay.
All right.
So, what we'd like to do is have you in an exercise in spiritual assessment. So at each table, I think we mentioned, we have a spiritual assessment tool which actually uses some of these questions that Marie has covered. So what we'd like you to do is pair up, find a partner, and each of you choose the role of either caregiver or patient. And then the caregiver would use the mini spiritual assessment tool and conduct a spiritual assessment with your patient to feel how asking these questions are, and the patients how it feels to answer them. But we'd like to say also, patients, because you are role-playing, your data can be fiction. So I'm going to invoke with love Sister Angela. Did I make myself clear? So hopefully we could spend the next, Marie and I will give you some notice, because we would like to bring us back together and talk about the challenges and the opportunities, which is really the other part of our work that we're going to be embarking on. On the back of those forms, you'll notice we have some reflection questions. What did you experience in this exercise? Do you have any recommendations for us? And are there any models of spiritual assessment currently out there in practice where it's actually occurring in the practice of nursing or health professionals that you think would be helpful for us in our journey? And if so, if you wouldn't mind jotting that down for us, and Marie will collect them.
Yes.
Is that what you like to do, Marie?
Yes. What I'd like to say is if you could have all what time is it now? Oh, perfect. Mm-hmm. We would like to finish the spiritual assessment and the notation in about 15 minutes, mm-hmm. Okay? Then collect all of them, and if we could just have one person come up and just bring them to the the stage, and then we're going to go on with our reflection.
We'll close out with challenges and opportunities.
Yeah, we're going to close out with the challenges and opportunities. Thank you. And please fill this out, because we're going to actually use them as part of our criteria and our research. Thank you.
Very happy and excited to see so much dialogue. So what Marie and I have taken a look at is challenges and opportunities for spiritual assessment, but our work and our goal is not to just begin and end with a spiritual assessment tool that's efficient and simple and comfortable for nurses or health professionals to use, but rather we want to step into the environment of care at that patient level, at the level of a patient unit or a department, and really address what we have come to learn are some of the organizational gaps and obstacles that have filtered down to the department level, and the gaps and obstacles there, so that when we do continue this work, that it is really putting into place a spiritual assessment process that will be consistent and will be sustained. So we have some challenges. First of all, and very of top priority, is lack of organizational commitment. And I have recently even had an experience at a Catholic health, at a medical center, Catholic medical center, and had a very lackluster response, shall we say, to my interest in having us come in and work with a particular unit. We also hear that nurses do identify time constraints and excessive workloads that inhibit them from doing a spiritual assessment, which is part of our goal in developing a tool that will be built right into the health and physical assessment tool, so that it's completed upon admission to a particular unit and that it is very time efficient. And Marie showed you the questions that we have developed thus far, but we're hoping that you might even have some recommendations for us. We have identified, of course, there's a lack of confidence and experience of caregivers. And that, we hope, will be addressed with an educational program. We don't believe that that nurses can be, practicing nurses have yet the experience. They receive more of a theoretical framework for spiritual assessment in their nursing programs, and then really being able to practice it is a whole other dimension. And then lack of continuity of care and lack of privacy has been identified. The lack of continuity of care is really a key issue, because now we have the rapidity of length of stay, where patients are admitted and discharged very shortly. It doesn't leave a lot of room for nurses to develop a patient-nurse therapeutic relationship. And I remember back in the day when I practiced nursing, and I'm not going to give you a date to give it away, but I was an oncology nurse. But back in the day, we were we would round with the residents and say, "Oh, I don't think that this patient should go home until next week sometime because our teaching isn't done, or we've got the family coming." Remember, we had the beautiful luxury of really having input into a length of stay where we could accomplish it. But more than that, the entire environment in the hospital has changed to such, and I know I'm speaking to some very experienced people, where the patient is not even in their bed and we're discussing when they're to be discharged. And that a nurse has a 12-hour shift, and when she returns, the entire complement of patients has changed. So that's something that we want to address in our work with feeling comfortable and confident in providing spiritual care. There's also unit and department-based structures that we need to address that support spiritual assessment. One is lack of tools, lack of a process, lack of expectation, lack of understanding of pastoral care and services. These are all things that we have learned. And there is also an element of patient and or family resistance that we would incorporate into our education of nurses, is that we do, after doing a spiritual assessment, of course, it is the patient's choice and the family's choice for how we proceed. These are some of the opportunities. We know, as I indicated before, that nurses and physicians have an interest and a desire to provide spiritual care, and that there is a connection between mission and spiritual assessment in faith-based health systems. And that's something that we hope to be able to illuminate as we spread out into some of these organizations to share our vision and have partners willing to work with us. Also, another opportunity is the emphasis on technology for enhancing efficiencies. So really being able to use the electronic medical record, the EMR, to incorporate the spiritual assessment. And then the final bullet is something that Marie and I have talked about. I have indicated it as an opportunity. And this is is seeking the support of nurses and or physicians and or other health professionals or health care givers who are called to assist as spiritual leaders. Part of our vision is, as we create this model that will occur within an acute care setting on a unit, that we would be able to have a designated spiritual nurse leader. And that individual would be a coach, would be support to their fellow nurses, etc. And the reason why I think that this could work and be accepted is because we have coaches and facilitators of various other projects on these units with the huge thrust for quality and safety. There are huge process improvement projects where there will be a named person as a champion of a particular project, and what they do is really oversee to assure that the particular project is being completed or the elements of it are being completed. So this is what we hope will also be part of our structure. Marie, did you have anything else to say? Oh, I wanted to say one other thing. I wanted to share a story just quickly, but again, about this unit-based process and expectation. As I've worked with Marie on this and Father Kaz and all of our reflections about this, I had to reflect back to my mother, who passed away a few years back, and she was 92, God love her, but she was my really strongest Catholic role model in my life. And she every night said her rosary with her prayers, her prayer book, and she every morning said her rosary with her prayer book. And her prayer book, by the time she passed away, was falling apart. But my mother had multiple hospitalizations, and every hospitalization, and she was in a Catholic hospital, 75% of her hospitalizations, there was another portion that she was not for surgeries. Every hospitalization, one of my siblings, either my brother or my sisters, who had to identify to the nurses that they wanted my mother's prayer book and her rosary within reach, right at her bedside, because she used it every night and every morning. And we had to we had to identify that every single hospitalization. And my vision is that we have a nurse ask a family member what we can do for you so that we can help to support your religious values and what brings you comfort and hope while you're here in our hospital stay.
Thank you so much, Kathleen. And I think that this has really provided an overview of what the need is, and we're looking forward to taking the evaluation forms and your spiritual assessments, and we'll be collating that data. So I just want to thank you for listening and taking this opportunity. Thank you.